So my name is Jack Lucas. I'm a medical student at the University of South Carolina here in Columbia. I'm a second-year medical student, and today I'm going to be presenting the Code of Concurrent Care for advancing the conversation around perioperative code status. So the main focus of the study was targeting patients in the perioperative setting with a documented DNR order. Previously at our institution, these patients were required to change their code status to full code in order to qualify for surgery, presumably because surgeons and anesthesiologists didn't want to operate or provide anesthesia for someone who they did not have the ability to resuscitate in the worst case scenario. In 1993, the American Society of Anesthesiologists came out and said that automatically suspending a patient's DNR status for surgery is unethical and violates patient autonomy. And since then, several organizations, including the American College of Surgeons, have come out and now recommend a documented reconsideration conversation with patients regarding their perioperative code status prior to surgery, which ensures patients are getting the care that they want. So in the last year at our institution, there was a change in the surgical consent form, which allows patients who would like to remain DNR to stay DNR for the surgical procedure that they're undergoing. And that's kind of the, I guess, stimulus or what led to this project. So our aims were to assess the hospital's current performance at handling perioperative code status in patients with a documented DNR order. And we also want to assess how general surgery residents feel about perioperative code status in terms of how confident they are and competent in having these conversations. And additionally, we implemented training for general surgery residents to teach them to be competent and confident about having these reconsideration conversations and also handling the documentation of the code status prior to surgery. So prospectively, we hope that if this training increases the number of documented reconsideration conversations with patients, and if these conversations do happen, our goal is to compare the number of patients who choose to remain DNR after reconsideration to the past where there was no documented reconsideration conversations. So in figure 1 at the top right there in the middle, we recorded results from our resident survey, and notably you can see that across all 5 years of training, the residents agreed that code status discussions are beneficial and necessary to their training. And additionally, most residents agreed that training was valued at our institution. However, the graph on the far right shows varying degrees of comfort performing these code status conversations, with PGY5s reporting the highest level of comfort and PGY1s reporting the lowest, which makes sense given the level of training, since obviously 5th year residents have a higher level of training and probably more experience having difficult conversations with patients. Additionally, in table 1, you can see our retrospective analysis of code statuses. This data represents a 6-month period and shows that out of 5,000 plus people undergoing surgery, that 344 people had previously documented DNR code status, which was the main inclusion criteria for our study. And out of these 344 people, 127 reversed their code status from DNR to full code for the surgical procedure. 104 chose to retain their DNR code status for surgery, and notably 113 had no code status in their chart prior to surgery, which highlights significant room for improvement in handling these patients and their perioperative code status. And like I mentioned earlier, we are currently collecting prospective data on the amount of reconsideration conversations performed by residents since our training implementation. And we are also looking to see if there is an increase in patients who choose to remain DNR after having these conversations. So sort of in conclusion, we hope that the implementation of code reconsideration training with general surgery residents will not only improve their competency and comfort handling these conversations, but also it will lead to improvements in the amount of reconsideration conversations documented in charts. And then hopefully with that, there will be better documentation of code status, and most importantly, I guess, preserve patient autonomy so patients can get the care that they want and they sort of understand all the medical jargon and whatnot that goes on with, explaining a DNR order. So.